I have already prepared the case in advance, just in case no one else wants to present. So the chief complaint this time is dyspnea and productive cough. And so this is an 80-year-old lady, 80 years old, who presented to the ED with 1 day of dyspnea at rest and productive cough with mucoid sputum. She'd also had a fever, and the maximum temperature was 39.5 degrees Celsius, and a diffuse rash with no pruritus and asthenia. And so when we tried to understand a little bit more of her history, she told us she also had worsening of her usual left knee pain 4 days before presentation, and swelling. It hurt at night, which was very different from her usual pattern. And 1 day before presentation, she also had arthralgia in her right wrist with rigidity, and it was worse at night and at rest. She reported no night sweats, weight loss, lymphadenopathy, hemoptysis, headache, nausea, vomiting, or abdominal pain. And I'll stop here.
Wow. Can you just present all the time? Thank you so much for always presenting such wonderful cases. So please always come join us. This is a very rich aliquot, so maybe I'll just take the first part and then pass the mic to Robbie to layer on the review of systems. So if you have an 80-year-old female who's coming in with kind of acute onset of dyspnea, productive cough with some of also arthralgias and rash. So kind of focusing on the dyspnea, we always say tempo is everything, right? So in terms of 1 day of dyspnea, you obviously kind of want to think about your no misdiagnosis, and center of dyspnea always tends to be the cardiopulmonary system. So, in terms of the acuity, there are no misdiagnoses, or your cardiovascular, your ACS, your pulmonary embolisms, those sort of situations. And when you think about fever and cough on top of that, it's hard to knock infection until proven otherwise. So I think in this person who's coming in with acute onset of dyspnea and cough, I'm thinking mostly about the pulmonary system, thinking about the parenchyma, and thinking about the alveoli, thinking about what is going on in there. And RG, what are your thoughts about the arthralgias and the rash?
Oh, I think your lay of the land is perfect to add on, and I'll just go back to a simple concept. Fever and shortness of breath should equal pneumonia until proven otherwise. That's because of the places you can get inflammation in the heart and the lungs. The lungs are exposed to the world and therefore much more likely to have infectious inflammation in them, unlike the parts that are not exposed to the world, like the pleura or the heart. And in order of prevalence, it's lung infection, pleural infection, heart infection. And in general, we think about pulmonary infections in 2 categories. The first category is normal organisms that are commensal, that live in our body, that cause infection by going to the wrong place. So these are things like strep pneumo, Moraxella, Haemophilus influenza, so on and so forth, that exist on your body and for many reasons can make it all the way down into your lungs and cause an infection. But there's a whole other category of infectious agents that cause pneumonia that don't come from your body, but they come from the world. These are things like virus, like COVID, atypical infections like Mycoplasma, Legionella, tick-borne diseases, spirochetes, mycobacterial diseases, other zoonotic or soil-borne organisms. So why is that distinction helpful? It's helpful because the organisms that are commensal usually cause a localized pulmonary syndrome with minimal disseminated features. So most patients who have staph pneumonia, strep pneumonia, may be systemically ill, but will not have many extra pulmonary manifestations unless they're immunocompromised and have disseminated disease, which is not unheard of, but not common. That's in stark contrast to the organisms that come from the environment, which are characterized by the near universal presence of systemic symptoms and manifestations in almost everybody. We all know that COVID is a systemic disease with respiratory manifestations. It causes kidney issues, liver issues, brain issues, thrombotic issues. Mycoplasma, Legionella all have extrapulmonary manifestations, as does all the tick-borne diseases, mycobacterial diseases, esoteric gram-negative rods that can come from the skin like Yersinia, tularemia, endemic mycoses that disseminate, so on and so forth. So from the get-go, this seems to be a pneumonia that is probably environmentally acquired. And the question is, does the rash and the arthritis help us prioritize what they are? And yeah, the rash is consistent with what you might see in mycoplasma as an initial priority. But there's one big caveat. The big caveat is, what if it's the heart? And the heart may be at play here with causing arthritis and a rash through the possibility of endocarditis. So I would be labeling this as a systemic disease with pulmonary manifestations, and wondering, is the systemic disease just diffuse cardiac disease to the cardiovascular system, or is it actually a pulmonary infection from an atypical organism? And you need a lot more data to figure that out, but I think stay anchored in the possibility that it's probably in the lungs and it's probably atypical. All right, Katerina, back to you.
Okay, so her past medical history, she has obesity with a BMI of 42, well-controlled type 2 diabetes on oral medication and no end organ damage that we know of, uncontrolled hypertension, complicated by left ventricular hypertrophy, but her ejection fraction was preserved in her last echo. Also degenerative osteoarthritis of both knees with marked functional limitation, and she never left the house because of this, and she needed crutches to walk, and also chronic lymphedema of the lower extremities. Her medications were enalapril, lercanidipine, furosemide, vildagliptin, metformin, and also daily paracetamol and ibuprofen for her knee pain. Her family history was irrelevant, and her social history, she couldn't read or write, worked at a preserves factory most of her life, but she was retired, was a widower, lived alone in quite an urban area in Porto, but never left the house, as I said. She had support from a neighbor to do her shopping and occasionally bring her food. She had no pets. There were only a few stray cats and dogs on her street. No contact with other animals like farm animals, not even in the vicinity. She only drank water from the public system. She had no travel history. She had never gone anywhere. And she didn't consume unpasteurized products. She never smoked, never drank, and had no drug use. Her immunizations were up to date. Flu vaccine was annual, and she had never done the anti-pneumococcal vaccine. And this was before the time of COVID. This is important. No allergies. Her vitals, her temperature was 38.3. Her BP was 138/68. Her heart rate was 120. Her respiratory rate was 24. And she was sitting at 91% on room air. She was in no acute distress. Her cardiovascular exam was normal. There were no murmurs on auscultation. Her lung exam was normal. There was nothing on auscultation of her lungs. Her abdomen was also normal. Her neuro exam, she was alert and oriented ×3, no meningeal signs, no focal signs. Her extremities, she had the lymphedema, very pronounced lymphedema, but it wasn't different from her usual. Her left knee was very swollen indeed. It was very different from her right knee and tender to palpation, but there were no other inflammatory signs. And both her hands were very swollen. And there was tendinosynovitis of the right wrist. And I can show you a picture of her rash, if I can share my screen. Alrighty, here we go. Okay, This was a rash. Yeah, and we can pause here.
It's super, super intriguing. Maybe I can just take the background data and then have Charmaine guide us through her thinking through the exam. And you know what struck me in the background data is the presence of lymphedema and the history of diabetes. I also am marveled by Katarina's very thorough ID infectious disease like review of systems, which is absolutely amazing. And just goes to show that you have to be thinking about an exogenous organism here and get the history about pets and foods and whatnot, which I'm not surprised that Katarina thought through. And you know, if you're thinking about patients with diabetes getting infections, there's a whole list of organisms that patients with diabetes are at higher risk for. But in terms of the ones that can have a center of gravity in the lungs, I'd say it's important to think about a lot of gram-negative rods. So in patients in East Asia, for example, they can get melioidosis, you can get pseudomonal pneumonia. But also the spotlight extends to thinking about certain fungal infections, including the most morbid of mucor, but also the most applicable potentially here is Cryptococcus. Mucor is probably not at play given that her diabetes is well controlled. And melioidosis is probably not at play since she's not from East Asia, but I will say that the geographic spread of melioidosis is extending, and actually there's an outbreak here in the United States as we speak. That's it for the diabetes. I think you might think, hey, could this be disseminated Cryptococcus, which is not robustly associated with diabetes, but I think you should think about it. And then in terms of lymphedema, lymphedema might be a play in two different ways. One, some patients have been diagnosed with idiopathic lymphedema that actually have a systemic disease that causes lymphedema, like yellow nail syndrome or some of the other primary lymph syndromes. I say yellow nail syndrome like I know it and see it for others because we've presented on the podcast to Reza, who had a terrific discussion. So you should check it out if you haven't heard it already. But I think that there's a lot more fun stuff in the physical exam, which I'll pass on to Charmaine to analyze.
All right, thanks, RJ. Yeah, I just want to say that social history was just infectious disease level history. So thank you for providing that. In terms of the exam, I think in terms of her vital signs, what caught my eyes was that she was febrile, otherwise she didn't require any oxygen, and her vital sign at the moment was stable, which is always great because then it gives us time to think about it. What jumped out the most to me on the exam was the normal pulmonary exam. I always like to think about a few caveats with the pulmonary exam. And this is, I think about like the operator, which is me. And oftentimes when we're examining the patients, you know, in busy clinic situations, we might just not be hearing an abnormal sound. If patients not taking deep enough breaths, you might not pick up any abnormalities. So I think still like getting further imaging would be helpful. That being said, if the pulmonary exam is like completely normal, what makes sounds is like the alveoli is your bronchial trees. So it puts the focus more on the vasculature. If the imaging is negative, if the exam is completely normal, which is not where I started with this case, for example, as Ravi mentioned, it was like most worried about like a pulmonary source of an infection. So now thinking a little bit more of vasculature involvement, whether, you know, if it's any kind of like vasculitides, vasculopathies, and I think still like septic emboli to the lungs are still good to consider. In terms of the rash, the right one does look a little bit petechial to me. I think it has a purplish hue. Was it palpable or non-palpable?
It wasn't palpable, sorry.
It wasn't palpable. Okay.
No, it was purple.
Purple. And was it blanchable or non-blanchable? You know?
It wasn't blanchable.
It wasn't blanchable. Okay, great. So if it's not blanchable, then it means like blood has already extravasated to the skin. So I'm thinking about like, you know, your vessel wall integrity, and perhaps it's kind of like there is a process that is interfering with your vascular wall integrity. So again, like I think in terms of like infection, and now like perhaps like some of the autoimmune comes to play, but again, the onus I think for me is to rule out infectious etiology. Infections can also be paired with like kind of autoimmune phenomena. I think endocarditis is notorious for that, that you can have joint involvements too. So getting like blood culture, getting an echo, getting some imaging and cultures to get labs, you know, the usual workup to be able to make diagnostic process. RG, are you thinking anything else that comes to your mind?
No, I love it. I completely agree with you.
Cool.
Yeah.
Kat, I can't wait.
Okay, here we go. So some labs. So her white blood cell count was 6.6 with 80% neutrophils. She had some lymphopenia. Her absolute count was 0.76. Her hemoglobin was 12.1. Her platelets were 210. Glucose 220. Creatinine 0.85. BUN 43. T-bill 1.15. And the Direx bilirubin was 0.64. AST was 40, ALT 43, ALK-Phos 156, albumin was 3, total protein was 7.14, sodium 135, potassium was 4, and her C-reactive protein was 388. Her ABG, her pH was 7.46, CO2 37.4, O2 54.2, bicarb 27.2, and lactate was 1. And this was on room air. Her chest X-ray only showed discrete interstitial pattern bilaterally and marked cardiomegaly. Her abdominal and ultrasound was normal, and she was started on ceftriaxone and admitted to our infirmary.
All right, maybe I'll just tackle the first part of the labs and then leave the rest to the one and only Robbie MG. I think in terms of the CBC, what caught my eyes was the lymphopenia. And in terms of like the lymphopenia, again, like sepsis, if someone is like septic, they can be lymphopenic. It makes me usually lymphopenia alone, like thinking about HIV, thinking about like more viral infection that sometimes often present with lymphopenia, you know, COVID being a notorious one as well, but just any acute process, especially someone coming with the 1 day of symptoms with like septic physiology can do that. There are medications like methotrexate, this patient is not on any, that can cause that. And then there are more rarely like autoimmune phenomena like lupus or immunodeficiencies and cancers can cause that. But again, in someone who's like coming in with acute infectious processes, I think, you know, my suspicion for like kind of bacterial is a little higher, but again, like viral etiologies, you can see it. So I would have RJ layer on that CRP and all those other just X-ray findings.
I love that analysis. Breaking down lymphopenia like that is just beautiful. You know, I'm giggling because I wish we had more time, but I will tell you this. My mother, who's a teacher and not in medicine, called me this morning and said, you know, your uncle's CRP is 133, so it must be either a cancer, infection, or rheumatism. And I was like, holy smokes, what have you been reading? And she's like, I learned this on WebMD. And I was both very proud and very disappointed of her. And then we proceeded to share and break down my uncle's CRP, which is probably a mild viral infection. But I think a CRP of 388 is quite impressive. And I think it really reinforces that the patient has an infection. And the clue that we have is that the X-ray shows something. And the problem with any organ is your instinct is to say, oh, I see something in an organ, so it must be the cause. And here you might say fever, chest X-ray, infiltrate equals pneumonia. And because it's interstitial and because there's a systemic signature, it's an atypical pneumonia with a non-pyogenic organism. But the problem may be that there's nothing wrong with the lungs themselves and they're reflecting cardiogenic pulmonary edema, in which we go back to the hypothesis of endocarditis. I think the one thing to recognize is we tend to say that mycoplasma, which is something you should think about in a diffuse pneumonia plus rash, we tend to say that that is an infection of young adults, but that's not true. A large fraction of mycoplasma is in older adults, such as this patient, who have more very serious disease. So I think my actionable step is to follow up what the blood cultures show, to recognize that a murmur may not show up because the patient's tachycardic. Consider empiric treatment for endocarditis with vancomycin and ceftriaxone, but more importantly, this patient needs an intracellular antibiotic, I think. So I would be thinking about azithromycin or doxycycline for this patient, in addition to sending, in this patient, I don't think we send or should send infectious diseases serologies for patients with typical community-acquired pneumonia, but there's nothing typical about this. So I would send off Legionella, I would send off blood cultures, and I would send off a mycoplasma serology and see if that sheds light on what is happening. All right, back to you, my friend.
Okay, so a few more exams. So she didn't get better on ceftriaxone, and she was started on peptizo only, and didn't get better as well, expectedly. Some more exams that she had done, we CT'd the chest, and she had diffuse ground glass opacities bilaterally only. Her HIV serology was negative. Her CMV and EBV serologies were consistent with past contact. Her troponin was normal. Her echo had left ventricular hypertrophy that we already knew, and a very large left atrium, but no vegetations. Her blood cultures were negative. We also sent for Legionella antigen in the urine, but the pathologist didn't agree with us, so they didn't do the exam. And we also sent for serology for rickettsia, mycoplasma, and leptospira, which were all negative. Okay, and then the next aliquot, I will tell you the final piece of the puzzle.
This gets trickier and trickier. I think with the echo, you've proven that to a high degree of certainty that the problem lies within the lungs themselves. And I think focusing on that was really, really wise, and what infectious causes could be happening. So I think this is a time where you'd be probably digging a little bit deeper to say, what is the two things. Like, you'd be trying to dig deeper into what infections could we have missed that caused this, but also at the same time start to wonder, could you be dealing with a non-infectious process? And you go back to a simple approach of, is this water? Probably not, because the heart's okay. Pus, we should think about more infections, or blood. And the blood possibility is to think about this being a rheumatological disease with a rash, joint symptoms, and diffuse alveolar hemorrhage. And so your clues into that might be a drop in, a progressive drop in hemoglobin. Or if the patient's not too sick, actually PFTs with a high DLCO can be a clue that you have hemorrhage. But yeah, I think this case is very, very tricky, honestly. And pass the mic to Charmaine to see if she has any wisdom or insight to add.
I would be calling our pulmonologist and be like, hey, do you want to bronch and let us know what's going on? To be honest, I think at this point, as Robbie beautifully mentioned, I think the differential still remains why the question is like, hey, is this like still an infectious process, or are we thinking more of an autoimmune? Is that really DAH? So I think I would really, I would ask for help at this point to see if we can get some more information from lungs, where we think might be the center of this disease right now.
You know, Charmaine, the weird part about this case is, which I didn't think about until now, prompted by Kushal's comment in the tweet, is in the chat, is the tenosynovitis and what that does. And I think we're programmed to think tenosynovitis, think a Neisseria gonorrhea. I don't think there's a reason to think about that. Syphilis can also do it. And then the two atypical organisms are mycobacterial infections. TB is notorious for doing it. And then, as Kushal reminded us, sporotrichosis. And so I wonder, like, we don't think about TB often enough in the Western world, but a patient who's 80 was alive in the time where TB was pretty common here. So I think I start to wonder, be like, are we missing TB? And the other thing that caught my eye was, oh, I didn't know that. You have to teach us about that, please. That's really cool. Yeah, I think is this TB synovitis, tenosynovitis and pulmonary, but also just know that the teaching we get in the United States about sporothrix, which is disseminated through soil. In Brazil, the most common dissemination of sporothrix is through cats. So it can be a cat-acquired disease, which maybe her exposure is there. But yeah, I think you got to talk to Palm, and you got to, honestly, while you're talking to Palm and waiting for them to come back, like, go crazy nerding out, like, enjoy it. But those are my crazy nerd out pearls. I don't know if
I love it.
In the middle of my rambling, you thought of anything else that you wanted to throw in the mix before we give Katerina the mic back.
I love listening to you nerd out on medicine. So that was fantastic.
You're just compensating now for my initial awkward comments, but I appreciate them very much. All right, Katerina, back to you.
Can't wait, guys.
Okay, so we started her on azithromycin, thinking that, okay, this really sounds like a typical infection by something intracellular. And the truth is, she got better. And when I was about to order a bronch and order a full autoimmune panel, like any good internal medicine resident, I checked her results from her labs, and we had a diagnosis. So we had a serology, IgM and IgG positive for Coxiella burnetii. So Q fever was the final diagnosis.
So good. Charmaine, thoughts?
Oh man, like Q fever, like there are a lot of diagnoses actually that humbles me in medicine. TB, lupus, and Q fever is one of them. I always like forget how far those spores can travel, so Q fever. That was brilliant. Kat, what are your thoughts, Robbie?
Oh, it's so good. It goes to show you epidemiology in Spain, Portugal, southern France. Yeah. Q fever is not so curious. I bet it's pretty common. But teach us, please.
It isn't that common in Portugal. A significant detail I left out was that this happened in August.
Ooh,
so
summer pneumonia.
Yeah, summer pneumonia. It isn't really common. It was the first Q fever I saw and the only Q fever I saw. We see a lot of not a lot, but more Bartonella infections than Coxiella infections. So it's not that common. What we do have a lot of, and I was saying in the chat, is TB. We have a lot of TB still. Especially in the north of Portugal where we are, because there is a lot of mines and working in the exploration for rock, and so we have the perfect cocktail in certain areas of people who work in mines and they go together in a little van, and after work they go and drink. So this is the perfect cocktail for tuberculosis. So we still have a lot of that. And in Porto, we still have a lot of problems with IV drugs, so a lot of HIV as well, and so TB because of that. Yeah, so a lot of TB in Portugal. So yeah, I hope you enjoyed the case. I certainly enjoyed seeing the final diagnosis and the patient getting better.
That was so fantastic, Kat. You're just such a wonderful, thoughtful doctor, and it's just such a pleasure learning from you, and the way you present the cases, the way you always ask the why, dig deep, and I was like, at some point I was like, oh, I wonder like if you just start empiric doxy on this or is it true? So that yeah, thank you for doing that. moving this patient's care forward. This is so fantastic. Always a pleasure, RG. Thank you, Kat. I cannot wait to hear Rafa's teaching points.
Oh, thank you, Caro. That was amazing. I bet Chriselle was really happy with this case as well. So we had this patient with dyspnea and productive cough. And then Charmaine reminded us that there are some known misdiagnoses when it comes to acute dyspnea. We had to think about cardiological pulmonary etiology, such as pulmonary embolism and the ACS. And then when it comes to fever plus productive cough, Rabbit taught us that we always have to think about pneumonia until proven otherwise. We can divide the pneumonia into two: normal organism and organism from the world. This is important because when you have normal organism, could see localized pneumonia, usually it's not disseminated unless the patients are immunocompromised. And from the world, like endemic mycosis, Legionella, and atypical infections, this is typically a disseminated syndrome. And when it comes to the background of this patient, we saw that this patient had diabetes, and we have to find that this patient had an increased risk for certain infections, for example, gram-negative rods, fungal infections. And then there's this pearl about hypoxemia that Charmaine reminded us. First, we have to check the pulse oximetry to see if it's working properly. And secondly, we have to see if this patient improves with minimal oxygen. If yes, we probably are dealing with a normal AA gradient. It could be seen in causes, for example, high altitude, hypoventilation, opioid use, or increased VMR leading to hypoventilation obesity syndrome. If not, we have to think about increased AA gradient. We could divide that into three etiologies: VK mismatch, right left shunt, and diffuse limitation in the setting of fibrosis. And then Charmaine reminded us that if the physical exam and imaging like chest X-ray, CT are all negative, we have to move away from the parenchyma and pleural space and think about the vessels. And finally, which was the diagnosis, we saw that this patient had Coxiella burnetii, Q fever, which is a zoonotic infection. This could lead to many manifestations, including flu-like illness, pneumonia, which was the case, hepatitis, acute endocarditis, maculopapular rash that this patient also had, and meningitis and encephalitis. So thank you, everyone. Such a nice case, and hope to see everyone tomorrow.
Boom, Rafa. Fantastic job. Thank you all for hanging. We really appreciate your time and all of the amazing discussions in the chat. We'll see you tomorrow. Bye.